Hi everyone, thanks for listening to my presentations. Today I'll be talking about Rhesus and repeated abortions prevention. Rhesus has a link with a monkey called Rhesus macaque, but I'll not go into details of that right now. So sit back and let's review Rhesus and how it's affecting pregnant women and how we can prevent that. We are all aware that there is a Rhesus positivity and also Rhesus negativity, and that it is a problem in pregnancy, and also that it is not without consequences. But the big question is, to what extent? Epidemiologically, Rhesus D negative blood is between 0.5 to 15% worldwide. So don't bother yourself too much because not many people will have Rhesus D negative blood problem, but the 0.5 to 15% that will have it worldwide, that's enough for now all of us to be concerned about, right? Okay, let's go. Okay, let's go over parental status quickly and see where we're going to have problem and where we will not. Rhesus negative mother with Rhesus negative father, no problem. Rhesus positive mother with Rhesus positive father, no problem. Rhesus positive mother with Rhesus negative father, no problem. But when we have Rhesus negative mother and the father is Rhesus positive, we will start working on that mother from now. And I will take you through everything we're going to do. And at delivery, we will test the blood of the newborn. If the newborn is Rhesus negative, hello, no problem. However, there will be a big concern if we have Rhesus negative mother and the father is Rhesus positive and the fetus is Rhesus positive and the newborn is Rhesus positive. There will be sensitization leading to alloimmunization. Alloimmunization is the immune response against foreign antigens after an exposure to a genetically different or non-self cells or tissues from members of the same species. Awareness. We know when you're pregnant and you're attending antenatal clinic, your blood group will be determined and that of your spouse. So when you see something like A plus or A minus, that is your blood group A with Rhesus D, or your blood group A without Rhesus factor. So that is the meaning of the plus or negative sign there. And lastly, if someone is O positive, it means blood group O with Rhesus factor present. If it's O negative, that is blood group O without Rhesus factor, that is O negative, okay? The plus or minus sign is Rhesus positivity or Rhesus negativity respectively. Okay, Rhesus positive mother, meaning that she had the antigen on her red blood cells. In reality, we have tens of antigens, up to 50 of them. For example, we have D, C, C, E, and each can induce antibodies. No problem, however, with a Rhesus positive or negative fetus from anyone. That is, if the mother is Rhesus positive, there's no problem whether the father has Rhesus positive or negative, or the fetus is now positive or negative, there's no problem. The problem is with the mother that is Rhesus negative. So if she is Rhesus negative, which means no D antigen, but there is that probability of anti-C, E, and C, and she's married to a Rhesus positive partner, if the fetus has inherited Rhesus positivity from the father, then this lecture becomes very, very important. When a Rhesus negative mother is exposed to a Rhesus positive fetus who had inherited the positivity from the father, or pre-pregnancy, the woman had inadvertently been exposed to a Rhesus positive blood, the maternal alloimmunization would develop due to immune system. And that will be forming anti-D immunoglobulin antibodies. The formed anti-D immunoglobulin antibodies will be present in that mother. The antibodies can cross the placenta to the fetus, destroying the red blood cells in Rhesus positive fetus and become phagocytized by macrophages in the spleen later on. We need to have a kind of open heart when handling Rhesus issues in pregnant patients. For example, a pregnant woman is attending antenatal clinic for the first time today, and we want to determine the Rhesus status, either blood group typing, and she's negative. Then we have acid, and then it's positive. Then we're wondering what is the cause. Okay, let's go. Any Rhesus positive blood transfusion prior to pregnancy can give alloimmunization. Okay, any hematopoietic stem cell transplantation can give that. Any needle contaminated with Rhesus positive blood can give alloimmunization. During delivery, so even before delivery, so let's forget the notion that pregnancy, father is negative, even outside pregnancy, a Rhesus or Rhesus negative mother could become sensitized prior to the first pregnancy. And previous abortions, because somebody is just married to a new husband right now, and the husband is Rhesus negative, and saying, oh, I'm free, I'm happy, I'm negative, my spouse is negative. How about previous relationships, previous abortions, and you didn't know the status of those fetuses that were aborted, either spontaneously or induced? So, could be from previous abortion. Alloimmunization can also be caused by ectopic pregnancy, abruptio placenta, trauma, retained placenta manually removed, or bleeding in pregnancy. Other possible causes could be procedures affecting the fetus, like coroning villus sampling, amniocentesis, external cephalic version, or caudosynthesis. Also, molar pregnancy could be responsible, fetal death could be responsible, and of course, antepartum hemorrhage. So all these could be responsible, but another key is even without pregnancy, when this woman was very young, if she has received blood transfusion that was not properly screened and it was having Rhesus factor, and now she wants to be pregnant, and now she was born with Rhesus negative status, but inadvertently had been transfused in one way or the other with Rhesus positive blood, then there might be a problem even in this very first pregnancy. Negative mother and positive fetus. I'm not trying to address characteristics in terms of behavior here. It's about Rhesus factor, okay? The first exposure to Rhesus positive fetus should trigger our intervention. If no anti-D immunoglobulin, then that will lead to development of anti-D antibodies acquired from the positive fetus or acquired from blood transfusion and so on. And that will cause lots of problems in future pregnancies. When is alloimmunization diagnosed? Alloimmunization is diagnosed when anti-D antibody is detected in the maternal blood. The fetus is not yet affected at this stage, but the fetus is at risk. The possibility of hemolysis causing hemolytic disease of the fetus and the newborn is high. The first pregnancy, if the first pregnancy is expected to be free from the immune reactions, only if that is the first time the woman will be exposed to Rhesus positive fetus, which means she's only been sensitized. But subsequent pregnancies may suffer if no Rogan has been given within 72 hours of delivery. Most cases are not due to the first pregnancy, so sensitization has occurred before, and the woman is now pregnant for the first time. She's negative, right? But the spouse is positive, and the fetus is now positive, but it's the first pregnancy, not knowing that she had been sensitized before. Then the first pregnancy will also suffer. In future pregnancies, there's likelihood of hemolytic disease of the fetus and the newborn, leading to hydros fetalis. Spontaneous abortion is very likely, stillbirth, and of course, if the fetus should survive in utero and delivered, there's likelihood of neonatal complications. I will go over that in the next slide. Okay, the baby has been delivered. In the first 28 days of life, there's likelihood of hyperbilirubinemia, leading to lethargy, hypotonia, and kernicterus. With kernicterus, the child might come down with hearing loss, seizures, and of course mental retardation. There's likelihood of anemia, heart failure, and even death. The confusion. Well, there should be no confusion anywhere. If the doctor will ask all the appropriate questions and the patient will be ready to supply all of them accurately as well. So the first confusion or the question is, at what stage in life did this woman with Rhesus negative blood first encounter Rhesus positive blood? And the history will be, have you ever been transfused in the past? Any needle you think you've used that could be contaminated with Rhesus positive blood, or any abortion in the past, so on and so forth. Okay, even transplantation, bone marrow transplantation, and so on. When was the first Rhesus positive fetus, or any blood transfusion before now? Then, to clear that, you can assay for anti-D immunoglobulin G level right now. So with that, you know the status of this Rhesus negative mother. Okay, history of previous abortions. Should a woman with previous abortions have anti-D immunoglobulin assay right now? The answer is yes. And someone is asking me the question then, why would she have to do that? Because she didn't even know the Rhesus status of the aborted fetuses in the past. That's it. The test that could be done would be in all first pregnancies presenting for antenatal, We should have blood grouping and Rhesus D typing of both the mother and the potential father. Then anti-D antibodies should be assayed using COOP test today. Positive indirect COOP test is a sign of Rhesus incompatibility. Still on test, if the woman is Rhesus negative, we're going to repeat the antibody screening at gestational age of 28 weeks and also at delivery. We're going to screen the baby at birth. If the baby is Rhesus negative, we don't need to give Rugan anymore. No need of screening at delivery for a mother who had been negative prior to this time, and the baby is out screened and the baby is also negative. Then no more screening for that. The cycle of high bilirubin in the newborn within the first 24 hours, and that will be a good indicator that we're dealing with ABO or Rhesus incompatibility. So we will assay the bilirubin level in the newborn within the first 24 hours. If it's very high, then we're dealing with pathologic jaundice. And the most cause will be ABO or Rhesus incompatibility, and of course, touch could be responsible. Caution. We have to be cautious while interpreting our lab results. We cannot make the diagnosis of alloimmunization if this woman had received Rugan in recent weeks. No. But if she had been given Rugan in the last few weeks, the assay will be very low. But if we assay the antibody and is very high and is IgM, then it is allo antibody. The exogenous Rugan will not give very high titer level of the antibody, and it will not be IgM. Rugan will give IgG. Let me explain again. I've just said in the previous slide that when we are interpreting the lab result, we should be cautious. Because if this woman had received Rugan in the last few weeks, that we may not be able to make the diagnosis of alloimmunization. But if that is the case, if she has been given Rugan and we assay the antibody a few weeks after, the value of the antibody should not be excessively high. It will be low if it is effect of the Rugan. And the immunoglobulin will be IgG. But if the assay is revealing a very high titer and the immunoglobulin is IgM, then it is not the effect of the Rugan. It is actually allo antibody. Treatment. If mother is already Rhesus antibody positive, which means alloimmunization has occurred, then all we need to do is to know the status of the fetus. And we have to find out if the fetus is having anemia or the fetus is having Rhesus positivity. And we'll be following the mother with serial measurement or serial assay of the anti-D titers. And we'll use ultrasound for fetal well-being. That's all we could do in situations where the mother is already known to have Rhesus antibody positivity. Intrauterine transfusion is possible, and we can plan an urgent delivery depending on the gestational age. Right now, the investigation is ongoing as per the use of combined intravenous immunoglobulin with plasmapheresis in the mother. Okay, the fetus has survived in utero. The pregnancy is to term, peaceful delivery, and here is the neonate. The neonate could be faced with hemolytic disease of the newborn, and then the treatment here could be exchange blood transfusion. We also do that in a very high level of bilirubin, but if it's a bit less, we can give phototherapy. That is in hyperbilirubinemia. There will be no need of exchange blood transfusion above if while in utero there was intrauterine transfusion. However, intrauterine transfusion can suppress normal erythropoiesis. Therefore, every month we have to top up the transfusion and then have complete blood count and hemoglobin down. If alloimmunization has already occurred, no more Rogan, can use surrogate mother. If in vitro fertilization occurs, then we have to test the status of the embryo. A Rhesus negative embryo can then be transferred and carried by the mother even if she's having alloimmunization already. You know why? Since the embryo is not having rhesus factor, there will be no damages done. But Rhesus positive fetus will have problem. Rhesus negative fetus will come out like all other normal pregnancies with normal features, normal everything at birth. Prevention. From all that I've said before now, it's obvious that in any woman of childbearing age, no Rhesus positive blood transfusion, please. No Rhesus positive blood transfusion in any woman of childbearing age. Still on prevention. Once this mother is known to be Rhesus negative and the spouse is Rhesus positive, and we've assayed the antibody and is all negative right now, then we'll get our Rogan ready. We'll give that at this first encounter at Neonatal clinic. We'll also give after each invasive procedure like amniocentesis, choledocentesis, coronary sampling. And after any report of bleeding during this pregnancy, we administer. By the time we reach age 28 weeks gestational age, we administer again. At delivery, we'll do two things. The first thing is we'll get Rogan ready. Then before administering the Rogan, because we may not need it, we will go and assay the blood of the newborn. If the newborn is Rhesus negative, then we will no longer need the Rogan. But if the newborn is Rhesus positive, we will administer that Rogan within the first 72 hours. And with that, I've come to the end of this presentation. Many thanks for taking your time to listen patiently, and I hope this will help someone somewhere, and you yourself, you are fully educated right now, and might be able to help someone somewhere. Thanks for listening. Please remember to subscribe, remember to share. I appreciate it.